Good evening, everyone. My name is Erwin De Leon. I'm Columbia University School of Professional Studies Chief Diversity Officer, and I'd like to welcome you to tonight's CLE program, which explores the very important subject of our ethical obligation to address implicit bias and microaggressions in healthcare. I would also like to thank the Bioethics program and Professor Hoffman in particular for hosting this program, which is part of the larger initiative ongoing in our school to make sure that every student feels like they belong and are part of our community. David?
Thank you so much, Erwin. I appreciate your being here to put your presence behind this program, because this effort at addressing implicit bias and the negative effect of microaggression is something that doesn't get enough attention. And so tonight's program is really just a first step toward getting everyone to understand what has been sort of a hidden epidemic. And so I am joined by two colleagues. First, Nakia Alexander, who is a registered nurse, practicing nurse up at the New York Presbyterian Hospital, Columbia University Irving Medical Center, and Jorge Rivera, who is an alumni of our Bioethics Master's Program and is a member of the faculty of the Bioethics Program and also counsel to the New York State Senate for health issues. And I'm thrilled to have both of them with me to have a conversation. And this is really a conversation about the need to address what is a standard of care issue, meaning that this is something that we need to be recognizing not as an enhancement to care, but as an essential element of the obligation to provide ethically responsible and clinically complete care to all of our patients. So Nakia will be focusing on the clinical perspectives because she's a practicing nurse, and Jorge will be applying both his training as a lawyer and as a clinical ethicist to enhance our understanding of how these kinds of implicit bias and microaggression issues come up in the course of providing bioethics consultation. I will pull this all together to make this relevant to the history of quality improvement in healthcare so that everyone who is with us tonight can take away from this evening a better understanding of why we all, as clinicians, lawyers, ethicists, need to make this part of the conversation in every encounter with every patient. Haley, can I have the next slide, please? So what we're going to be talking about is this notion of implicit bias. And we're doing this from a legal perspective and from a clinical perspective. And we're doing this to train clinicians and also to train lawyers in the way that they advise their clients. So this is the necessary legal notice because, yes, some of us are lawyers. This is the process you need to follow if you're going to be seeking continuing legal education CLE credit for tonight's program. Haley, next slide, please. And just a little bit of, just a slight lag there, just a little bit of context for what we're going to be discussing tonight. This is the agenda that we shared with you as part of the invitation to join the program. First, we're going to be looking at what it means for there to be a standard of care from a clinical, ethical, and legal perspective. Then we're going to look at the impact of implicit bias on meeting that standard of care. That is, to answer the question, why does this matter? Next, we're going to be looking at this from the bedside. What is the experience of our patients where implicit bias and microaggression are part of their patient care experience, which is unfortunate to put it mildly. Then we're going to turn to an analogous situation that I actually confronted earlier in my career with a kind of implicit bias against patients who didn't speak English as their primary language, what we refer to clinically as limited English proficiency or LEP patients. And we're going to wrap this up by a discussion and sort of a call to action for all of us to take ownership, take responsibility for doing something to convince all of our colleagues on the legal, the clinical, and the ethical side to fix this, to commit to ameliorating this notion of implicit bias and the notion, which is unfortunately prevalent, that this is a normal part of the healthcare delivery system. Because, as I hope you are convinced by the end of the evening, it most assuredly is not and should not be. Haley, next slide. So, first, why are we here? What is the purpose in gathering clinicians, lawyers, ethicists to talk about implicit bias? It is because it impairs the clinician patient relationship. It cheapens and diminishes our ability to create a coalition and a joining of interests with our patients. And if we don't take this seriously, the nature of this implicit bias, the corrosive effect of this phenomenon of microaggression, something that those of us who have been in clinical care for a while understand has been around and shouldn't be. So we need to fix that. Next slide, please. And so let's start with a definition of microaggression as a form of implicit bias. And Nakia, can you discuss this? First, present it, and then discuss with our collected community the context in which you received this perspective from a patient.
So should I define implicit bias first, or should I just define?
Sure.
Okay, so when we speak about implicit, we are speaking mainly about the unconscious. Implicit bias refers to the attitudes, stereotypes, beliefs that occur outside of our conscious awareness and control. This is what affects our actions and decisions. Implicit bias manifests into microaggressions, which is defined as subtle and verbal, nonverbal insults. They're denigrating messages communicated towards a marginalized person. Sometimes the person that's giving off these messages may be well-intentioned, but unaware of the impact of their words or actions to the potential target. This quote was actually a quote from a patient that I had because she felt as though nobody was listening to her. Nobody was actually taking her care seriously. And so she said that she feels like she has to constantly advocate for herself because she didn't feel like people were advocating for her. She didn't have anybody in the healthcare field to advocate for her. And this patient happened to also be a lawyer. So this was something that she had said to me, and she had also seen my presentation. I have done presentations on microaggressions, so this was something that she said to me, and yeah.
It's quite startling, especially coming from an attorney. And frankly, we can be grateful to this patient for sharing this perspective, because the biggest problem with implicit bias is that it is so often unrecognized and unacknowledged, both by the person who is perpetrating the bias and often by the people who are on the receiving end. They don't even realize that the way they are being related to is part of the problem with the care that the patients are receiving. And that really is what we're trying to get at today, so that we start to raise consciousness, raise awareness of this problem. Next slide, please. So the issue that Nakia was just highlighting in recounting the conversation she had with this patient is this notion of a standard of care. And, Nakia, I'm curious, how do you perceive standard of care generally in your patient care? In what context is it typically understood, your duty of care and the level of care that you're obligated to give?
So, from a clinical standpoint, it is the care given from one person to another, taking into account medical knowledge, evidence-based research in which doctors, nurses, and clinicians practice. I believe that we take in both ethicals and we also take it in from a legal standpoint as well. But mostly as clinicians, as nurses, as doctors, we work from a clinical standpoint. And ethics does get involved as well. So,
indeed. And Jorge, as a clinical ethicist, what does the standard of care mean to you, and how should we be thinking about a standard of ethical care from an ethicist's perspective?
From an ethicist perspective, I can't not divorce that from the background I have, and we talk a lot about patient-centered care, but I don't want to individualize it solely to the patient. There are people or entities or individuals around that patient that in a way determine that standard of care and what that patient-centered care means, right? And from an ethical perspective, yes, we talk about, well, the standard of care is patient-centered care. Patient comes first. But in a sense, there's also another side to that coin, which is it doesn't happen in a vacuum, right? There are people and contexts that determine that relationship, that standard, and we should also, from an ethical perspective, take into account that part of the equation as well.
Absolutely. And all of that, the sort of clinical standard of care, meaning what is competence, what is the appropriate level and expertise in the treatment that is provided, and the ethical standard of care being the respect that we show for patients in delivering care and in being guided by the patient's values. All of that adds up to the legal definition of the standard of care, which for the purpose of our discussion tonight, really we need to think of in terms of what is the standard, such that if you fall below that standard, you have rendered substandard care, you have departed from the standard of care, understanding, of course, that a departure from the accepted standards of care, that's the definition of malpractice, right? And so the point I want everyone to take away from our discussion tonight is that when you provide care that is disrespectful and alienating and distancing, as between clinicians and patients, and also for that matter, as between clinicians, you are providing substandard care. You are committing malpractice. Next slide, please. And this was made most clear in 1969 in the case of Canterbury versus Spence, which was argued before the United States Court of Appeals for the District of Columbia Circuit, the busiest court of appeals in our nation. And it focused on this notion that something as simple as informed consent and treating the patient as a partner is something that can give rise to legal obligation. And in this case, next slide, please. The court was looking at a variety of issues, all of which centered around this notion of what a doctor needs to tell a patient as part of the conversation about the care plan, what the patient's diagnosis is, what their prognosis is, what can reasonably be expected to be done for the patient. And this was an interesting quote from the decision. I'll read it. The court also held that evidence, including evidence that the patient progressed after the operation until he fell while unattended. But a few hours thereafter, his condition had deteriorated, and testimony that there were complaints of paralysis and respiratory difficulty, and medical testimony that paralysis can be brought on by trauma or shock, that is the fall, presented an issue whether there was, and this is the important phrase, dereliction of the hospital's duty to exercise reasonable care for the safety and well-being of the patient, and an issue of causality. That is, did that neglect cause the patient harm? And this is not obvious, but is very relevant to our discussion about implicit bias, because when a patient feels alienated from their caregivers, there is that lack of therapeutic alliance. There's a lack of trust. There's a lack of confidence in the care that's being given. And that notion of dereliction, again, another definition of malpractice that can be applied to a patient falling, or can be applied to a patient losing trust and confidence in their caregivers because of microaggressions, because of implicit bias that has gotten woven into the way care has been provided, and that we are here to call out. Next slide, please. So in this context, what we want to change in the way that healthcare is delivered is to amplify this notion, also from Canterbury versus Spence. Physician has duty as a facet of due care to warn of dangers lurking in proposed treatment and to impart information which patient has every right to expect. Reasonable explanation required means generally informing the patient in non-technical terms as to what is at stake, i.e. the therapy alternatives open to him or her, goals expected or believed to be achieved, and risks which may ensue from particular treatment and no treatment. So in Canterbury, what happened, interestingly, was the court said this standard of what ought to be disclosed, what ought to be shared as a conversation between the patient and the clinicians, is not measured by what the clinicians think is reasonable, but rather is measured by what the patient thinks is reasonable. Next slide, Haley, please. In this regard, the court said, coming right up, nor can we ignore the fact that to bind the disclosure obligation to medical usage is to arrogate the decision or revelation to the physician alone. And that's what was rejected. Respect for the patient's right of self-determination on particular therapy demands a standard set by law for physicians, rather than one which physicians may or may not impose upon themselves. This is fascinating because this is to say that unlike the standard of what a physician is technically capable of accomplishing, this notion of showing respect for the patient's rights should be determined by a community standard, not by standards created by clinicians. In this case, in 1969, all focus was on physicians. We've changed that substantially. But this is the duty that we are trying to extend beyond what clinicians, physicians, think is reasonably expected of them. So I'm going to turn to Nakia and ask you, Nakia, do you see patients understanding that they have a right to be treated with respect? Is that something that patients that you're seeing at the hospital understand today?
I believe at times they understand that. Some patients understand that. There are patients that don't know all of their rights in the hospital. We have a Bill of Rights that we have to follow. A patient should know their diagnosis. They should know their differential diagnosis, and they should know if the doctor doesn't believe that for instance, if a patient has chest pain, did the doctor check for a heart attack? Did the doctor check for a pulmonary embolism? Did the doctor check for bronchitis? There's a bunch of different diagnoses that could be associated specifically with the chest pain that the patient may have. And if they don't believe that the patient is having a heart attack, what did they do to make that determination? Or if they believe that the patient didn't have a pulmonary embolism, what did the doctor do to determine that the patient doesn't have a pulmonary embolism? And the patient has a right to know what tests or what studies have been done to rule all those other diagnoses out. But I don't think that every patient gets that. I don't think that every patient gets all of the risks. We see it all the time. Patients didn't know that they would be in pain after surgery, or patients didn't know that there might be a bleeding. They don't know that they're at risk for a blood clot. So you have patients that don't know. And so when we're giving them medication, we let them know as nurses, but some patients, some clinicians, they don't tell them, So I don't think that every patient experiences that privilege equally, or in this case, it's supposed to be a right. But I think that there are some patients that receive that privilege, and there's some patients that don't.
Absolutely. So let's now turn this conversation to the way that implicit bias, and let's call it by a different name, racism, influences the way patients experience trust in their clinicians, and what we ought to be doing to make sure that enhancing and reinforcing the duty of trust is part of the obligation of respecting patients' rights to be full participants in their care. Jorge, can you talk about your experience dealing with patients when their decision-making capacity is one of the clinical issues that needs to be addressed, which obviously has an ethical dimension, so that we can understand how racial insensitivity and microaggressions and implicit bias all corrode that obligation of respect for the patient's right of self-determination?
Sure. And definitely it was, I would say, in incapacity assessments or those kinds of ethical consultations that I saw the most, I would say, racism, like you're saying, right? And for example, I had an African-American female that she didn't trust the medical team for whatever reason. And the first conversation I had with the team is like, oh, she doesn't have capacity. And I was like, why? And she's like, oh, she doesn't want to talk to us. And I'm like, okay, that doesn't mean she doesn't have capacity. We need to, let me have a conversation with her. Let's see where this is going. But that's the connection that they made automatically. Oh, she doesn't want to talk to us, then she doesn't have capacity necessarily, right? And having that distrust, even having the conversation with, for example, the medical ethics team about understanding that this patient has a distrust towards this particular team, they were like, oh, if she cannot, for example, give us a reason why she's distrusting, then she really doesn't have capacity. And that's where we go about and say that it's a very big issue about the magic words that we've talked about before in other conversations. If we don't hear those magic words, I don't know why automatically everybody thinks they don't have capacity, but it's all of it. And it's because of those magic words that we really need to listen, when at the end of the day is really having a conversation and listening to whatever the person's saying, not expecting a magic word, right? And in other cases, for example, another African-American male that he just didn't want to engage with the medical team, right? And again, I got called and they're like, oh, he doesn't want to talk to us, so it's because he doesn't have capacity, right? And again, that connection was very concerning because it was something that happened way too often. And I can say it with almost every minority group that I saw while doing my fellowship, for example, right? And after having a conversation with him, I realized that he was having somebody guiding him outside of the hospital, and all of his questions and all of his worries, he channeled those through that person. It had nothing to do with his capacity. It was only about who that person trusted to have those conversations, right? And that's something, again, that I don't know why it was so difficult to make that kind of connection, but it took some time from the medical team to understand, for example, that it has nothing to do with a person's capacity, but it had everything to do with that patient's trust towards the medical team, right? And we have other. You can go ahead. Sorry.
No, go ahead. I'm sorry.
No, for example, another conversation I had, another ethics consult, for example, a Latino patient, that after having a conversation about having a particular transplant or not, he was really not making a choice for the medical team, right? He was there, but not really making a choice. And the first thing they thought was like, oh, he can't make a choice, so he's really not communicating, he's not stating his wishes, so there must be something wrong with the capacity, right? He might not have capacity. When really you need to understand, for example, in particular Latino families, there is what it's called familismo, or the just the regular family dynamics, that you take or you make a decision in conjunction with the rest of your family, right? You just don't make a decision by yourself. And I was joking the other day with you, David, for example, if I end up in a hospital, I would never make a decision myself, even though I have full capacity right now, right? Because that's just how it works. If I'm ever in a hospital, my mother's going to be making decisions for me. It doesn't matter what happens. And that's okay. We can defer to that, right? And in the bioethical sense of all this, or at least the bioethical questions that we philosophize about choice paralysis, right? And the insurmountable burden of the questions that we ask our patients, when it's simply a question of who this patient is, this cultural underpinning that's driving this patient's decision or this patient's presentation to you, right? It's not simply nothing to do with a person's capacity. It's all about where this patient is coming from, what are, in a sense, their lived experiences, right? And how those really determine the 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 relationship that's about to happen in that hospital stay.
Absolutely. And by the way, all of you in the audience can feed questions to us. We'll take them as they come in. Don't save your questions for the end, because we can't know what you're concerned about and what you need to be empowered to address in taking on this task of attacking and ameliorating implicit bias. And this is a chance to have a dialogue. So you can ask your questions in the chat box, and we will answer them as they come up through the course of the evening. We'll get to the first question in just a moment, but I want to tie what Jorge was just saying into the basic notion of respect for patients, because part of the problem that we confront, and it's something that Nikia will be talking about more in a few minutes, is this notion that people who perceive patients as being different from them are sometimes treated as if they are not as capable, to Jorge's point. And that's a basic violation of the simplest notion of a standard of care. Next slide, please. I find it hard to have any discussion about patients' rights and bioethics without grounding it in the articulation of Justice Benjamin Cardozo, which my students all commit to memory before the end of any of my classes. And this was something that Cardozo wrote in the case of Schloendorf versus the Society of New York Hospital in 1914. And Cardozo said, every human being of adult years and sound mind has a right to determine what shall be done with his own body. odd and unfortunate, and I would argue inherently biased framing, since Schlöendorff was Mary Schlöendorff. And the medical treatment involved was decidedly female. It involved the presence of fibroids in Mary Schlöendorff's uterus. And she gave very explicit instructions to the doctors to go in and see what the problem was, but not to do any surgery, not to take anything out until they had discussed it first. And guess what happened? The doctors went in 1914, right? No remote imaging, X-ray, ultrasound, none of that. They did what is called exploratory surgery. And so they looked inside Mary Schlöendorff's uterus and they saw fibroids, and they just decided, we're going to take them out. So it's hard to build a relationship of trust between a doctor and a patient when the doctors, the clinicians, are not respecting the explicit instructions of the patient. Now, in 1914, the notion of patient autonomy and the notion of the patient as consumer was pretty foreign. In fact, when Cardozo wrote these words, the way the medical community received his articulation of a right to determine what shall be done with their own body was considered heresy. The predominant ethic of the day was the notion of medical paternalism. And what we are talking about when we discuss implicit bias and microaggressions and racial insensitivity or gender insensitivity, as was the case here, what we're talking about is a notion that people who don't agree with their treating clinicians deserve to be ignored. And that is antithetical to everything that we are trying to build in an ethical model of care today. But we have over 100 years of history, even since the notion of a right to consent was formulated in the case of Schlöendorff, that we're now working against. And bear in mind, what Schlöendorff demonstrated was not a right of informed consent. That would take many decades more to percolate up through the healthcare delivery system. This was the simple notion of basic consent. Consent just to be told what is going to be done and to say yes or no. The notion of informed consent didn't enter the standard of care until much later. And so we need to confront how the lack of sensitivity to these forms of implicit bias, whether they are against people based on their gender or against people based on their race or ethnicity, how that corrodes and undermines the type of care that meets the standard of care that is non-negligent, non-malpractice level of care. Next slide, please. So next we have to ask ourselves, what is the impact of implicit bias, which we have now defined, on meeting the standard of care? And to understand that, we really have to understand what implicit bias is in the context of care. So Suzanne asks the very obvious and important question, what does implicit bias mean? Is that racism? Nikia, what do you think?
Sorry. So yeah, no, implicit bias is not necessarily racism. Implicit bias, it accompanies racism. Like it's implicit bias is the big umbrella, while racism falls under that. We all have implicit biases. We all are fed images from birth till now, from things that we see on TV, from images that just in our textbooks, in our study books, from our parents, from our friends. All of that affects our biases, and that affects how we end up treating people. Racism is a part of it, but that is not everybody that has implicit bias is a racist. And you can have implicit bias, and if you know what those biases are, that can affect how you treat people. So everybody has implicit bias. It does not mean because you have implicit bias that you are a racist. But I think specifically some of the things that we have talked about so far has, been some form of racism. So
And if I can add to that, for
okay,
example, something that's not racist and something that but feeds into that implicit bias, for example, is not prescribing pain medication to a patient with opioid use history, for example. It has nothing to do with racism in a sense sometimes, right? There is some racist undertones to that in some cases. But for example, it can come from a bias in a case, for example, that I heard saying, oh, he's a junkie. Why would we give him pain medication? Right? And it doesn't necessarily mean that we're being racist. It's something else as well, right? Um,
And that is, in fact, the crux of the dilemma here, is that we don't have clear associations. We can't say every time this happens, the person's motivation is racial insensitivity or racial alienation, or the notion that the clinician doesn't understand the values that derive from a patient's ethnicity. Jorge's point about decision making by family members being a ethnic and cultural value is a good example of that. So when we talk about how do we know, well, guess what? Nakia is going to have some really concrete and tangible examples of that in just a few minutes. But from a standard of care perspective, we have to understand, as with Mary Schlowendorf, anytime you are not acting respectfully because you feel as if the patient isn't equal to the task, doesn't have as much basis for making care decisions as perhaps the clinician thinks they are able to make, that is a bias. If it is unconscious, it is implicit. And as you will see from the examples that Nakia will share in a few moments, we're going to have a couple of videos to look at. Oftentimes, what is at work is one of those insidious kind of biases based on race, ethnicity, cultural differences between clinicians and patients, and frankly, often cultural differences between caregivers, between physicians, therapists, technicians, nurses. This crosses all of those boundaries. And that's what we are trying to get out in the open and to articulate a basis for framing those forms of insensitivity as inadequate care. Because if you're not treating your patient respectfully, if you're not making them a partner in their care, you are damaging the relationship between the clinician and the patient that needs to be intact if there is to be useful and productive care for that patient in a manner that the patient feels they are being respected. So we definitely have some work to do there. Next slide, please. And the way we have to do this is to look to ourselves, right? No one comes with a flashing light on their forehead when they say something that is biased and unkind and insensitive. I'm being racist now. It would make our work much easier, but this work is not so simple. So we need to look to ourselves to ask these questions, to take a more affirmative responsibility as care providers, whether clinicians or ethicists or lawyers who are advising clinicians and institutions. When can we, in fact, identify these misconducts, these kinds of misbehaviors, as indicative of some failing in the way that we are providing care, such that we have a obligation, a clinical, ethical, and legal obligation to remediate those deficiencies so that we are providing better care? So we have another question, and thank you, Shonella, and I hope I pronounced your name properly. The question is, how can the impact of implicit bias be measured and counteracted if it is not conscious. Nikia, do you have any thoughts about how we can take something that can't be measured and quantified and nonetheless act on it?
So sometimes it can be measured. They've done many studies on people's implicit bias, where they've asked doctors, nurses, clinicians, what do they think here? There's plenty of studies that, and I think Jorge touched on this, but in regards to, and I'm sorry, we will show a video about this, about Black people and pain. And they've done studies where they've shown that first year and second year residents had believed that Black people's skin was much thicker than white people's skin. And sometimes when we have pain, when Black people are in pain, it's not taken as seriously. So they've done studies that's shown that implicit bias does have an effect on healthcare. Sometimes it really does take surveys to help with that. Sometimes it takes another person to point it out. That's why you have presentations like this where people even look within themselves. Like I said, I have implicit biases that I've recognized within myself, and because I recognize that, it makes me more conscious. So when I go out there into the world, I change my behavior. So an example of that would be, and I'm going to give, my name is Nikia, and it's often mispronounced. And when I meet other people whom have what a quote unquote different name is, sometimes I change it to something that I feel is more simpler. But that invalidates that person's name, and invalidates their culture, and invalidates everything that that person stands for. And I used to do this all the time throughout college. And I'm admitting to it because I realized that this is actually a problem. It's only when I started doing this research did I realize that I was actually a perpetrator of a microaggression. So what I ended up doing was, when people say, "This is my name," and I don't know how to pronounce it, I'll ask them again and again and again until I make sure that I get it, because it's important for me to get it. And that is a form of an implicit bias that I was unconsciously doing, and I realized that I had to change that behavior because it shows a level of respect. So it's other people pointing it out. It's research, it's surveys, it's platforms like this. That's the answer.
Yep, absolutely. And it's all of us through events like this and through the kind of training that Nikia will be describing in a few minutes, that we can start to take these biases from the level of unconscious to conscious, so that we have the ability to correct it. Jorge, do you want to comment on Shaunalla's asking if we ought to be distinguishing between unconscious bias and implicit bias? Because I think that reveals a lack of acceptance that just because it's unconscious doesn't make it okay. And that's something I think we need to come to terms with. So what's your thought on that?
In a sense, I do see them as the same thing. In a way, I don't want to get caught up in the vocabulary too much, because I think it's more of a practical issue in a sense. And being unconscious or implicit, I basically just use them interchangeably. I'm not sure if Nikia has something different to say about that, but for me, they're just essentially the same thing, or at least they have the same effect. I don't know.
Nikia?
I'm sorry.
Do you have a sense of whether we ought to be distinguishing between unconscious bias and implicit bias? Should we accept that? Go ahead.
They are interchangeable, yes. So when we speak about implicit bias, we're talking about the unconscious. However, there are some forms of microaggressions that are intentional, the person is intentionally trying to hurt the other person, and they are conscious of what they're doing. But it is something that's like far, far back, because sometimes those people that's saying it are saying that they're not racist, or they don't hate this other group of people, or they're not trying to hurt this other group of people, but they are.
Mm-hmm.
Right.
Right, and this is actually sort of capsulated in the phrase, "Oh, it was only a joke," right? When somebody says something that was clearly conscious and intentional, but was nonetheless an implicit bias because they weren't coming right out and saying, I don't think this person is normal. I don't think this person is like me. I don't think this person is someone who, even though they are my patient, who I have to treat as my equal. And any time we see, and frankly, we say this a lot in the hospital. There's a whole sort of subset of vocabulary that is a kind of gallows humor. It's a coping mechanism for dealing with difficult situations, with patients becoming ill, injured, and dying. But when it crosses over to be an attack not on the circumstance, but a criticism of the patient themselves, such as a comment or a remark followed by, oh, it was only a joke, that is a microaggression, conscious or unconscious, implicit or explicit. That's part of the problem. In fact, maybe implicit bias lets people off too easily. Maybe we need to frame this as something that is more specific to intention and not whether it is sufficiently overt to no longer be merely implicit. Any thoughts on that? Are we letting people off too easily? Well, let's take a question from Kyle. Oh, I'm sorry. Go ahead, Nikia.
I don't necessarily think that we're letting people off too easily. I think that it takes constant education. There are people that don't even believe that their biases exist. I think those are the ones that are probably the most dangerous. So I think that even letting them know that this is a bias, and I think that comes from constant education. I think we have to we have to start there. So I don't know necessarily that it lets people off too easily. I think that is the hard fact. That is the hard truth. It is something that is supposed to be taken very seriously, and I think it requires constant education.
I would agree.
Yeah, actually, go ahead, Jorge.
It's definitely a constant. It's a constant work. It's not something, for example, that you would sort of fix it in, say, a training, and that's it.
Right.
And even trainings would give way to more biases. And I'm sure we'll talk about it a little bit later, but it is constant work that takes a lot of patience because the biases are always creeping out again and again and again, and it just takes a lot of work, and it's not easy, but it takes commitment,
Right.
So Kyle asks a question that really goes to the heart of this point. Kyle asks, what is an ideal mechanism to police substandard care as it relates to implicit bias? Medical review boards, the legal system, patient advocacy organizations. And Kyle, I think that the answer given by Nikia just now is really the start of the answer to your question, which is that we need to be talking to patients about this and letting them understand that what they may be accustomed to in their lives outside of the healthcare delivery system as just people being mean or people being inappropriate or people being childish or boorish. In the healthcare setting, those attitudes are interfering with the quality of care that the patient is receiving because it's breaking down that relationship of trust that is the foundation of all clinical relationships. So I would say, to Nikia's point, the first step is to educate patients that This is not normal. It's not acceptable ever. It is especially not normal, and it is a departure from the standard of care when it occurs in a patient treatment situation. And we're going to see an example of that in a few minutes. But yes, absolutely, this needs to be part of the way that doctors are evaluated. It needs to be part of the subjective quality of care surveys that are done, referred to as Press-Ganey surveys. It needs to be part of that whole measure, to Nkia's point, of what is the quality of the care that the patient perceives they're receiving. And if we do this through review boards, then maybe we stay out of the legal system, because nobody wants this to turn into more malpractice lawsuits. That will be a signal that we have failed in this effort, not that we have succeeded. But clearly, patient advocacy organizations have an important role. And Kyle, we're going to be talking about an analog situation involving LEP patients and a patient advocacy organization in just a few minutes. So we have the next slide, please. So for those of you who are here today, both to learn about implicit bias and microaggression, and also to satisfy your obligation for continuing legal education training on issues related to diversity, equity, and inclusion, here is your first participation code, which you will have to put down on your course attendance attestation and on your survey. And so the first participation code, write it down, is micro. And let's go to the next slide, please. So, Nkia, you are closest to patients most recently of the three of us, because you are currently at the bedside taking care of patients. Tell us what implicit bias looks like at the bedside, and how, from your perspective, is it undermining the quality of care that patients are receiving?
So implicit bias at the bedside, there's a potential dissociation between what a person explicitly believes and wants to do and the hidden influence of negative implicit associations of his or her thoughts and actions. How a physician communicates, including verbal cues, body language, and nonverbal behavior. It can be the frequency of eye contact. It could be where they stand in the room, how close the physician is to the patient. This may manifest in the subconscious bias. Bias can detrimentally affect whether patients seek care or return of care, follow-up treatment protocols. It could also influence outcomes of care. Numerous research studies offer evidence that implicit bias is associated with higher complication rates, greater morbidity, and higher patient mortality. There's extensive research that finds unconscious bias can lead to differential treatment by patients by race, gender, weight, age, language, income, and even like insurance. Bias in clinical decision making does result in either overuse or underuse of prescription medications. So some patients may receive more pain medication while other patients may receive less pain medication. Some patients may get physical therapy while other patients may not. That all is part of what it looks like at the bedside. Implicit biases can influence your diagnosis, treatments, decisions, lack of care, levels of care in some circumstances. And those actions could be part of microaggressions.
So Merrill asks a question that leads right into the next part of our program. Merrill asks, how can providers ascertain a potential microaggression in a given case? That is, how do you recognize it? How do you label it? Merrill goes on, there may be things that aren't obvious: ethnicity, race, gender, education level, and the provider may not know the patient, which is to simply say sometimes the clinician and the patient themselves don't understand that the nature of their interaction constitutes a microaggression. So next slide, please. So Nakia, you've done some remarkable work educating everyone on how to understand and identify microaggression both as the recipient and as the perpetrator. Can you talk a little bit about your training programs before we go to the videos that you brought with you today?
Yes, so I am a nurse at New York Presbyterian. I've been on this unit for about 4 years, but I've also been a nurse since 2013. So I've seen some things. I created a microaggressions presentation last year, and I've been teaching this presentation for about 1.5 years. It started because I had a pulsating feeling during the protest of George Floyd, Breonna Taylor, and Ahmaud Arbery last year. I didn't want to discuss anything else. As co-chair of the Cardiac Council of the time, I felt there was a need to discuss what was actually happening with the world and how it was potentially affecting other employees. My presentation into microaggressions now further transcends into healthcare and, most importantly, how we treat our patients. So I guess we can start with what is a microaggression. My presentation discusses different types of microaggressions. They can be backhanded compliments like, "You speak really good English," or "Where are you from?" or "You are a credit to your race." Or a very common one is like touching a Black woman's hair because it's fro or it's braids or it's because it's different, but touching it without permission. It could be confusing two people's names because they are of the same race, or confusing, like just mixing their names up. It could be something as simple as confusing a female physician for a nurse or a maintenance worker, or something like not using the interpreter service for a Hispanic patient or for a Polish patient. It could be something that resembles old-fashioned racism, which could be equivalent to a white person calling a Black person the N-word, or where former President Trump referring to the coronavirus as the Chinese virus, or intentionally not giving a promotion to someone that is Hispanic or Asian, or even not wanting a patient saying they don't want a Black nurse or a Muslim doctor, or not wanting to assess or appropriately assess a transgendered patient, or laughing or joking about their body parts. And by the way, the old-fashioned racism, this is the most conscious and most intentional form of a microaggression. It's called a micro-assault, just for reference. But there are many types of microaggressions. The microaggression that I named earlier in regards to changing someone's name to something that's simpler to me, like I want to call somebody Bob because it makes sense to me, is a micro-invalidation because I'm invalidating their culture. So I'm going to play my video. I believe that this video is actually part of my presentation that I've done. I think that it's a great introduction into microaggressions, and I think it helps people really understand it. So it's a short video.
For people who still don't think that microaggressions are a problem.
Oh, you're so well-spoken.
Oh, just imagine, instead of being a stupid comment, a microaggression is a mosquito bite.
Ugh, it's a compliment.
Mosquito bites and their itch are one of nature's most annoying features. But if you're only bitten every once in a while...
No, where are you really from?
Cleveland?
Sure, it's annoying, but it's not that big a deal. The problem is that some people get bitten by mosquitoes a lot more than other people. I mean, a lot more. Whether it's on a date...
Oh, your English is so good.
Excuse me?
Going grocery shopping.
You know, everything happens for a reason.
I'm just buying apples.
Commuting to work.
So when are you gonna have a baby?
Watching TV.
We have to keep the Redskins' name. It's part of our culture and history.
Or just walking down the street with your partner.
I couldn't even tell you were gay.
Mosquitoes seem to pop up everywhere.
Do you know John? Give me shopping advice. I love Cher too.
And getting bit by mosquitoes every goddamn day.
Can I touch your hair?
multiple times a day
So pretty. Can
Can I touch
your
it,
hair?
please?
Please.
Can I please?
is annoying and makes you want to go ballistic on those mosquitoes, which seems like a huge overreaction to people who only get bit every once in a while.
It's just a mosquito bite. Who cares? Just another angry black woman.
Of course, beyond just being annoying, some mosquitoes carry truly threatening diseases that can mess up your life for years.
Astrophysics? Maybe you should try less challenging, Major.
Ow, my dreams.
And other mosquitoes carry strains that can even kill you.
He looked like he was up to trouble, okay? I felt threatened.
So next time you think someone's overreacting, just remember, some people experience mosquito bites all the time.
You're all so exotic. Wow.
And by mosquito bites, we mean microaggressions.
So yeah, I think that video helps people understand microaggressions because they happen all the time. So currently I am working on a video. I'm waiting for full approval through NYP, but my video is different types of microaggressions in healthcare, and it pretty much is a series of skits done by friends and people and employees that I worked with. But I was inspired. All of the stories that I have created or I was able to put on display are from emails that I received after doing my presentation. And I got a lot of emails, and I read a lot of stories of things that just happened while at the hospital, even things that I've never experienced, things that I've never even could think of. And so this presentation that I did became bigger than me, and I felt like it was really important to get these stories out there. So one of them is a pretty big one, and I felt like this was most important. David did see my whole video, and I really do hope that one day, when it is approved, that you guys all get to see it, because it's pretty good. I know they're not actors, but they did a pretty good job. So yeah, so we can just play the next video so that you guys can see.
Rest assured, when your video is finalized and ready for its debut, we will have you back, because I think everyone who is here tonight and lots of other people need to see that complete training. It is quite remarkable.
Yes, I think
So,
that
Peter?
yes, Peter, thank you.
Oh, Dr. Smith, hi, I'm glad you're here. I was about to give you a call about patients in 59A and B complaining of a lot of abdominal pain. Is there any way you can come and assess them?
Yeah.
Okay.
We'll go see them right now. You want to
10 out of 10 they're complaining of? Both of them? Okay.
All right, thanks.
Thank you.
Hey, sir. How you doing? I'm Dr. Smith.
Not doing so well.
Okay, what's going on?
Just got this cramping, this abdominal pain. It hurts so much.
Okay. How bad is it on a scale of 1 to 10?
10 out of 10.
Okay. All right, I'm sorry to hear that. We'll get you some pain medication.
Thank you, doctor.
Okay. Hey, sir. I heard you're having some pain, too.
Hey, doc. Yeah, my stomach's really hurting. It has been throbbing all day, and I've been asking for pain medication as well. Can I please get something?
Okay. How bad's your pain on a scale of 1 to 10?
A 10 out of 10. It's just all right here. It just really hurts.
Okay. All right, we'll see what we can do. Okay.
Thank you.
Hey, so we just saw both of them. So let's do this. For bed A, we'll do Oxy 5 and 10 on the pain scale. And then for bed B, let's just start with Tylenol and see how that goes, okay?
Tylenol.
Doctor, can I ask you a question?
Yeah.
Both of the patients have the same diagnosis, but for bed B, you only want to order Tylenol. Why is that?
You know, for bed B, I think he probably has a higher pain tolerance, and I don't know, maybe he's drug seeking, so we can just start with Tylenol, okay?
We can't speak about microaggressions in healthcare without speaking about racial disparities in healthcare. There's a misconception that exists that Black people do not experience pain at the same level as other races of people. This misconception is deeply rooted in the history of medical science. In the past, Black bodies have been used as test subjects under the guise of medical research, as detailed in books like The Medical Apartheid by Harriet A. Washington. Or even more recently,
In 2016, in a study done for the Proceedings of the National Academies of Science, it showed that 40% of first-year and second-year medical students believed that Black people's skin was thicker than white people's. If these misconceptions continue, this will result in a race of people that is systematically undertreated and underdiagnosed.
Thank you. That is
Well,
a preview.
That was remarkable. So explain to us two things. Who do you want to spread this lesson to, and what is the lesson that we should draw from that specific clinical scene? Let's just put words to it.
This is actually for everybody. I don't think that this is specifically just to physicians. I think that this is to nurses, this is to patient care directors, this is for patient advocates, this is for the patient, that they have rights. So I was actually going to tell a story because a lot of people probably see this video and think this doesn't exist. This can't be true. And like I said, this is inspired. This is actually like a real story. Two different patients, one Black, one white, and this is exactly the conversation that took place. And the person that was telling the story happened to be a resident that was following another doctor, and she witnessed this actually take place where the doctor decided to write Tylenol for one patient that was Black and oxycodone for another patient. So 2 weeks ago, and I told David this story as well, I work also at another hospital. I'm per diem. Actually, at two other hospitals. But I had an experience 2 weeks ago where I received a patient in reports, and the first thing that they mentioned that this patient is going to be your most difficult patient. She's pain-seeking. I was just like, okay, you know. And pain-seeking is a term that we used. I don't know if you guys are all familiar, but it's really missing a word. It means pain medicine seeking. And typically when we say someone is pain-seeking, we're saying that they want pain medication or they're addicted to pain medicine and they're not really in pain. So I go in, I make my assessment, and this patient had a cyst on her bottom that was, she had a surgical procedure on that cyst, and she's prone to having cysts. So when I go in, I assess her, and it did look pretty painful. They did do a job on her, and she said that, she was in pain. So I said, no problem. I will, give you pain medication. I spoke with the doctors during rounds, and I said, listen, I don't know if the pain medicine is ordered properly. From my assessment here, the way that this pain, the pain frequency, it's not matching up. There's certain things that we look for as clinicians, as nurses, as doctors to make sure that adds up. The doctor was like, I didn't write the order. The attending said, I didn't write the order. Pain management wrote the order. But listen, she's pain seeking. And I was just like, well, why do you feel that way? And she said, because I know her. And I was just like, okay, well, why do you feel that way? She was like, I'm telling you that she's pain seeking, but if you like, you can reach out to pain management and they can fix the order. So I said, okay, I'll reach out to pain management. In the midst of doing that, somewhere about an hour and a half later, to call pain management to fix the orders, while I was on the phone, the attending ran up to me to let me know that she was discharging the patient. She said, don't worry, don't call pain management. And I was just like, oh, I thought we were trying to fix the orders. And she said, no. I'm discharging her. She's going home. Don't worry about it. And I was just like, well, I'm worried about it because I know that her pain management is like, her pain is not actually being appropriately managed. And we just discussed it during rounds. Anyway, I hung up the phone, and in my mind, I'm thinking, I'm hoping, praying that this attending that writes the discharge is going to fix the orders within the discharge. And because technically she doesn't really need pain management to do that. She has the ability to write orders. Shortly after, I printed the discharge, and this patient that was on 2 opioid medications and Tylenol was only discharged with Tylenol. And I said, this is not right. And now I want to be clear. When you're on pain medication in the hospital, it is assumed that when you're going home, the pain medication that you go home with will be less, but not that less. So I called the doctor, I called the residents that's working with that attending to say, hey, like, she's only going to be discharged with Tylenol. And it was like, yeah, that's what the attending wants. The attending said that's what she wants. I escalated it to the assistant nurse manager, then the manager. Then I called pain management because I'm like, there's no way I could do this discharge with just Tylenol. I know for a fact that this patient is going to be in pain. She had a surgical procedure. As I'm making all these phone calls, there's another nurse that's like watching me. I panic, and I'm in my mind, I'm trying to advocate for the patient. I'm trying to escalate it to the highest power. She's like, don't bother. She's pain seeking. I said, why does everyone keep saying that? She was like, oh, because we know her. And I was just like, well, maybe I offer a different perspective coming from an outside hospital because I don't know her. I'm not just assuming that. And she was like, well, she's always asking for pain medicine. I was like, okay, you mean all the other times that she was admitted to this hospital? And they were like, yeah, all these times that she was admitted to this hospital. And I was like, did she have surgical procedures? Yes. And I'm like, so she didn't need pain medicine back then? And it was like, well, yeah. And I was just like, and she's been coming to this hospital for about 10 years, right? And they were like, yeah. And I was like, so her pain tolerance is actually higher, right? Because she's probably been receiving pain medication for a considerable amount of time. So for me, if I had a surgery and I got pain medicine, it would be different to treat me versus somebody that's been getting pain medication for years. Mm-hmm. Their pain tolerance would just be higher, but it doesn't mean that they're not in pain. And so the nurse goes, but she's always walking around. I was like, because she had a procedure on her bottom. She can't sit down. She's in pain. The reason why she's walking around is because it hurts to sit down. Every single time I walked into the room, this patient was on the room, she was on her side. So anyway, it got to the point where the doctor was pretty pissed off at me. And I had to escalate it to everybody else. And the nurse manager and the assistant nurse manager was like, when they looked over the frequency, they realized that, I was correct. And I let everybody know that it's actually a big misconception that Black people do not experience pain, which I don't think that was a sentence they were expecting. I was actually even a little proud of myself for even saying it. But I know for a fact that she was in pain. In the end, the doctor told me to do the discharge. And I politely declined. I said that I didn't feel comfortable doing this discharge. If you want to, you can, but I don't know what else to do. I've been advocating for this patient all day. I didn't know where else to go. So I got a friendly, I got in trouble. The administrator had come downstairs at this point and told me that it is not within my scope of practice to not do the discharge, to not determine that a discharge is inappropriate. I showed the administrator, whom also looked at all of the pain, like my argument as to why this patient wasn't giving pain medicine, or why she wasn't being treated appropriately. And she said, I see what you're saying. Okay, but you still have to do the discharge. And I didn't feel right, because what ends up happening is that a patient like her is going to either end up right back in the emergency room. She's going to, if she gets narcotics, somehow she's going to abuse it, right? Because she's not actually, her pain is actually not being treated. And when she ends up back in the emergency room, they're going to say, oh, she's pain seeking. She was in here because of pain. She has pain. That's all we hear, because they're not appropriately treating it. And so I realized that I, myself, Nikia, who's not from this hospital, is fighting a system. The stated purpose of healthcare is to reduce pain and suffering. And so to condone healthcare inequalities, or to ignore it, is to condone the pain and suffering of marginalized people. It's to say that it's okay, it's not really right. These are just one of the examples that I used in the presentation. And I think for Black people, it's one of the microaggressions that happen for them is pain. For Asian and Hispanic people, language is definitely a microaggression that they faced. For for transgendered patients, they're faced with people making fun of their issues or body image, or to be dehumanized. There's people treat you differently, and they may not even realize it. And this doctor didn't believe, the one that I'm telling you about, the story that I'm telling you about. She didn't believe that what I was saying was true. She said that she's pain seeking, and she just kept repeating that response. And the whole hospital, she was, this patient in particular was one of the very few Black patients that were on the floor. And I was the only Black nurse that day. I did not have my union to back me up. I did not have, I didn't have anything. So, it's important to have people that are educated in this, because it affects the way that patients receive care. It can cause anxiety, it can cause paranoia, it can cause depression. It causes people not to return to work, not want to come to work, to call out. And like I said, it causes patients to not trust healthcare. I had a patient once that said that their stomach was itching. They said that they had a surgical site, and he kept saying it was itching. And sorry, not my patient. This was a situation that happened on the unit, and everybody ignored the itching, and that patient started treating their itching themselves with herbal oils. And what ended up happening was the oils infected the oils. She kept opening up the surgical site to add this oil in that area, and it caused more damage. And when they asked her why she did it, she said, well, I've been telling everybody that my stomach's been itching. Nobody's been, helping me, so I took it upon myself. And that's what ends up happening. So, yeah.
So, Jorge, how does this resonate for you as a clinical ethicist? Does this sound familiar?
Yes, it's too familiar, sadly. But
you get this all the time, Jorge?
Yes, I was gonna add on the power dynamic you described earlier.
Oh, yes.
And that is something very real. And for me, at least, as a clinical ethicist, I had a very privileged position because I came from the medical ethics consult service, right? And everybody would be like, oh, that's the ethics police, right? Or ethics. I would hear when I would go into floor, so ethics is here.
Yeah, and it's a big deal.
Right, and in a sense, I exploited that to advocate for my patients, but I was the only person, in a sense, doing that on the floor, right? Because I had that position of power to use it in a kind of a positive way. But when I would sit with fellows or residents or nurses, the question always came up, oh, how can I deal with this? Because sometimes my superiors don't listen to me, or I'm not in that position to tell them that they're wrong, or that maybe they should reconsider this, right? And of course, me being an ethics consultant, I'd be like, call an ethics consultant and I'll help you, right? Because and it is kind of an institutional response to have those divisions there to help, but it's only one piece of the puzzle. It really requires more of an open communication and more of what you did, for example, that bravery, and having that kind of level systems of steps that might help. And they're not the be all end all, they're not, but they can help sometimes, right? But it's having that kind of honest conversation from the get-go, and having that bravery that you had, for example. But it's difficult. It's difficult because the power dynamic is very real, and we're not the only person looking for a job, in a sense, right? We're very you can be like, okay, well, thank you so much for coming, don't come back tomorrow. That's something that happens, right? So we walk that fine line, and there is no perfect answer to it, but there are little things that we can do to ameliorate at least that, right?
And Jorge's example, the story he told about being the ethics consult coming on the floor and everyone sort of sits up and pays attention, that's kind of the point of our discussion tonight, right? It's these forces that are external to the normal processes of a healthcare institution that can be the influence that brings about change more quickly, more reliably, and frankly, without forcing people like Nikia to put their jobs at risk, to put their careers at risk, because that is what's going on. Let there be no mistake. It reminds me, in fact, of a experience I had when I was doing my bioethics training at Columbia 27 years ago. One of my teachers, early on in the program, this was a pilot program, it was the first bioethics training program of its kind in New York. My teacher said to me, "David, do you think lawyers are a positive or negative influence on the practice of ethical medicine?" And I answered yes, because lawyers are powerful players in our society, and they are going to either be a powerful positive influence, modeled by Jorge in the story he just told, or a powerful negative influence, as exemplified by the positions sometimes taken by hospital administration that are more focused on risk management than they are on the quality of patient care. And that's what we're here tonight to start the process of fixing. So that brings us to the discussion of how do we fix this, and is it even fixable? And so I'm going to take the lead on answering this question. But first, we have a question in the chat from Susan, who asks whether institutionalizing the practice of narrative medicine as a tool can help doctors identify their own implicit bias, or conversely, help clinicians identify the implicit bias of their peers. And I think the answer is a clear yes to that. And Columbia has an entire narrative medicine program that is specifically designed to get people to think more about the communication, both written and verbal, between clinicians and patients, to understand what it is they're actually communicating. Because in the scenes that were played out in Nikia's training video, clearly the doctor thought he was just practicing good medicine by only giving the pain medicine that was needed to a patient who needed it. And I think fairly, I mean, those were colleagues of Nikia's and they were just acting. But doctors who engage in that kind of behavior, and all of us who spend our lives in hospitals have seen it many times, probably thought he was doing the right thing in avoiding over-medicating a patient who he had decided really wasn't in pain, although the way that they acted out their symptoms, it was pretty clear that the first patient was lying back in bed, looked fairly comfortable, and was speaking in a fairly relaxed manner. The second patient was doubled over, holding his abdomen, speaking in a stifled speech. And to Susan's point, learning how to identify those cues of who actually is in pain, and then learning through training such as Nikia's training, how to put a name to the implicit bias, that notion of microaggression, what we might call micro-abandonment, right? Because the doctor was clearly providing substandard care to the second patient based on assumptions that he was making about the patient, pretty clearly based on the patient's race, right? And now we can't prove that necessarily. There's no scan or blood test to conduct to find out what a doctor's motivations were in treating two similarly situated patients differently. But if you see it often enough, it becomes pretty clear. So this leads us to the question, can we fix this? Is this actually repairable? Will the training, even if we did it for everyone that Nikia shared just a little clip of with us just now, will it get the job done? Is it possible to actually ameliorate the kinds of neglect and the kinds of mistreatment that patients receive because of considerations that have nothing to do with their disease, but have a lot to do with who they actually are? Next slide, please. And in that regard, I have a personal professional experience that tells me that we can fix this, that this is a situation very similar to a circumstance that I confronted and had to have my eyes open to in the early part of the 2000s, 2002, in fact. And the situation there wasn't racism and microaggression as we are defining it tonight, or implicit bias as we are defining it tonight, but a different kind of implicit bias, to be sure. And that was with regard to patients with limited English proficiency, which, as I said earlier, we call LEP patients for short. And you should understand, next slide, please, that in this situation, we were talking about patients for whom English was not their first language, where those patients were Spanish speakers natively, and where those patients were unaware that they were receiving substandard care because they didn't understand what kind of care they were actually even receiving. So this is a settlement agreement, a consent decree that was issued jointly by the New York State Attorney General's office and the Office of Civil Rights of the Health and Human Services Administration. And this had to do with my hospital at the time, Wyckoff Heights Medical Center, where I spent 21 years of my career, really coming to terms with the fact that we weren't providing the kinds of services to LEP patients that they needed to receive in order to get even minimally competent care. For the obvious reason that if a patient isn't able to express their symptoms and their response to treatment in a way that the clinicians can understand, which requires an interpreter if the patient doesn't speak adequate English with sufficient sophistication in English to convey information that the patient is perfectly capable of conveying in Spanish or whatever their native language is, then that patient isn't able to even obtain a proper diagnosis. And if the clinician can't communicate to the patient what the proposed treatment is in a manner that the patient can clearly understand, then by definition, the patient is not giving informed consent, is not giving meaningful consent, which means that the care that then is administered to that patient is not consented to. And Jorge, let me ask you, what is your sense of where we are with LEP patients today compared to the experience that I had with assisting LEP patients back in the early 2000s? Have we made progress?
Well, definitely, yes. We've definitely made progress. There is a lot of work, anyways, as usual. I was, as an ethics consultant who, like, my first language is Spanish, I was a lot of times pulled to interpret for conversations. And we try to do that maybe out of convenience. I don't know why, maybe it's like, oh, the interpreter really doesn't understand what I'm trying to do. That's a separate conversation, because we just tend to put people right there to interpret without having a conversation about actually what's going to happen. Because as we need to prepare the patients and the family, we also need to prepare the interpreter so they know the context, right? And that really determines a lot of their work and how well they do it. And that's something that maybe we really need to work on. But I would say definitely better than before, and with particular swaths of populations having a better access than others. I practiced in New York, where there was, especially in Queens and Long Island, where there's like huge diversity, and sometimes the interpreters weren't the best, but that's more of a systems issue. But definitely better than before, I would say. Yes, we've made strides in that sense. Yes.
And that should give all of us some encouragement that this can work, and with concerted effort and with the help of lots of partners, we can reasonably expect to communicate to our colleagues that this kind of behavior not only doesn't work and isn't justice, but it's not even minimally competent healthcare. So let's do a little bit of law. For those of you who are non-lawyers, please bear with us. Next slide, please. So what was interesting about this encounter that we had first with a community activist group, a group named Make the Road by Walking, you might now know them as Make the Road New York, they actually set up a picket line in front of the hospital to stage a protest to bring attention to the notion that we were not receiving we were not providing, adequate interpretation services to patients. And everyone was quite startled by the idea that we had not heard from this group. We frankly didn't know about the group. I was outside counsel at the time, and they decided to set up this picket line. And when somebody from security came into the meeting that I was attending at the hospital and said, what should we do? I sat there, frankly, a little startled because we'd never had a protest in front of the hospital before, but more perplexed by the silence because nobody knew what to do. And that, of course, bespeaks a lack of training and a lack of preparation. So I piped up, not being a shy fellow, and I said, well, invite them in, because what else would you do? And this group of, 50 or so people from Make the Road by Walking came into the hospital, and they presented their demands for change in our interpretation services and presented a survey, albeit not a particularly scientific survey, but a survey nonetheless of their community members that demonstrated that there were a lot of people who were unhappy with the way my hospital was providing interpretation services, and that we clearly needed to do something about it. Now, there are two ways you can respond to a situation like this. You can go the legal route, and in fact, that's what happened with the hospital right down the road from Wyckoff, Woodhull Hospital. They took a decidedly more adversarial approach to Make the Road by Walking. In fact, I learned, and this is a cautionary tale, that the reason that Make the Road by Walking set up their protest in front of the hospital before coming to talk to us is when they had first gone to Woodhull, they went to talk to administration first and got nowhere, and then set up their picket line. And so they decided, well, let's just go straight to the picket line at Wyckoff. And it certainly worked in getting everyone's attention. But we, from there, entered into a heartfelt dialogue, and actually the hospital and Make the Road by Walking became powerful partners collaborating to improve not only the quality of care in the hospital, but the message of receptivity to the community that they should feel good about coming to Wyckoff because this was a hospital that could recognize room for improvement and take action. So in the legal settlement document, you have these whereas clauses. Those are sort of the prefaces to the action items. Whereas Wyckoff, this is, the fifth or sixth whereas, Wyckoff subsequently made efforts to revamp its language assistance policies and procedures and significantly enhance the language assistance services rendered and the facility's ability to monitor them, and then just skip down to the bottom of the page. Whereas the parties herein desire to obviate further investigation or litigation, and it is expressly understood that with respect to the Office of the Attorney General's investigation, this is a compromise settlement entered into solely for the purposes of avoiding expense and inconvenience of further investigation and litigation. Next slide, please. And that is standard boilerplate language for we're not giving up the fight, we're just deciding to have this fight differently. And so what we agreed to, and this is the lesson of hope, what we agreed to was that, and it says right here when you get into the body of the document, which I've shared the entire document with you, I urge you to read it. It's a good way to fall asleep. Wyckoff shall comply fully with the obligations, terms, and conditions set forth in Title VI and the regulations promulgated by the Health Department, and specifically that within 30 days after the effective date of the agreement, Wyckoff would appoint a full-time language assistance coordinator who shall be responsible for implementing, coordinating, and monitoring Wyckoff's language assistance services for LEP patients. So there you go. To the question, I think it was from Sean earlier this evening, maybe not Sean. Yes, everyone has to step in. The clinicians have to own up to the fact that by not communicating effectively with their patients, they were not providing competent care. Community groups are needed to bring this out into the open, and the institution's lawyers, in this case me, have to take the more constructive approach. And I think we can accomplish this where implicit bias and microaggressions are concerned for just the reason that we were able to accomplish this where LEP services were concerned at my hospital back in 2002. So we have a couple more questions. Patrick asks, Nakia, can you comment on moral distress experienced by yourself and others when faced with pushback or animosity from colleagues when attempting to redress situations like the ones you described? So, Nakia, how did you deal with the strain and the tension that this experience creates for you, especially early on before you became such a superstar spokesperson for racial and ethnic justice?
So there's different ways to go about it. I think that that day, 2 weeks ago, I said to myself, is this the mountain I want to stand on? Like, am I gonna like allow myself to potentially get fired today? Once the administrator came down, I'm just like, I'm gonna go to nursing office. And that person was like, well, I run the nursing office. So, I'm like, I don't know what to do. I don't know what to do. And so I felt like I had to keep defending the situation until I couldn't anymore. But I'm not going to lie to you guys. I went home and cried. I cried. I was my boyfriend plays basketball, and I had to go to a game right after work. And I was crying. I was like, I'm just so emotional right now because who knows what else happens at this hospital? Who knows? Who knows? They won't have Nakia or anybody like me to defend the next person. And that makes me really sad. It makes me very, very emotional. In fact, the person that I have a contact person when I want to work, and I let them know. I was like, I don't know if I feel comfortable going back to that unit. And the person was like, well, why? And I had to tell her this like whole long story, and it made me feel uncomfortable, like showing back on this unit. Anyway, I did go back to work on that unit, and so it didn't actually like stop me because I actually do feel like I can make a difference. But it does, it can put a stress on you. It doesn't feel good, and you are stuck between what you want to do or what you feel is right, and versus what the hospital feels is right. And so my plan is to eventually write a letter. I started it. And I think that it's important to face microaggressions head on, because who knows where that can go. I dealt with a situation where I had an employee that I was working with tried to take credit for a presentation that I had, and they felt like they contributed to it, and I said, no, you did not. And in the end, I was really taken back by this person, because this person probably would be in rooms that I will never be in. I will never be invited to be in, and that could potentially not help me grow within the organization. And I decided to write that person a letter. explicitly showing them proof that they did not help me with this presentation. They didn't even have the presentation or any file of it on their computer. They didn't have the questions. They didn't have anything that went along with it. And then after I wrote the letter, I sent it, I told my manager what the situation was. I sent her the letter and I said, I just want to show you that I'm sending this letter. I'm just letting you know. And my manager was actually pretty shocked because she actually knows that employee. And she said, well, I can't imagine. I was like, this is what this person did. And my manager said, okay, send the letter. And I asked her, I was like, I need you to defend me if God forbid, I mean, if this person says something bad, or I was so afraid, but I felt like I had to send this letter because they were really trying to take credit for their work. And this person did happen to be of a different race than me. And for me, I believe that I called them out on it. I said that for years, white women have been taking credit for Black women's work. And I was very, very honest. I showed statistics in the letter, and it took me a long time to write it, but I felt like it was really important that she knew, that she understood. Anyway,
yeah, and
she gave me the respect
Nakia,
that I deserved. So.
Nakia, it sounds like part of the way you dealt with the moral distress that Patrick was asking about was to dive in, to step forward, as evidenced by the training program that you've developed. And I think that's what we need more of, right? Because that's what gets institutional resources marshaled to actually address a problem. Meryl asked a question about how the LEP situation played out at small hospitals that maybe don't have the resources that larger hospitals do to provide interpretation services in lots of different languages. And the reality is that even in the pre-internet era, we used a lot of technology, and first audio interpretation services and then video interpretation services were available using very clunky, very expensive equipment that had to be rolled around on a huge cart. But that was the measure of the institution's commitment to address the problem. And this led to statewide legislation and a national movement to create a new profession of LEP coordinator. And you now have LEP coordinators at hospitals across the country. That's the model that we need to emulate, right? That's where we're going with this. And that's why I chose to use the LEP experience as a case study for how we can succeed, because I do believe we can succeed. Next slide, please. So this leads us to the obvious question, what do we do? What can and what should clinicians, lawyers, ethicists, I left ethicists out, shame on me, do to address all of these problems of implicit bias? So we know what Nakia has done as a clinician. Jorge, what should ethicists do? And what should ethicists who are lawyers, just thinking of two happen to be in the room right now, what should we be doing? What's the next step?
Well, definitely advocacy, but I want to first take a step back and just want to underscore how training is definitely not enough, and it's definitely a great first step, but it's definitely not the be all end all. Like I've said earlier, most of these trainings, we sometimes even just are clicking away our life in front of a computer, and then we are experts in implicit bias, right? And that's not how it works, right? It's not like that. And because there is something bigger happening in the background, and things that we learn in training sometimes are very fundamentally divorced from understandings of power, inequality, and all those things function, or at least those trainings that don't at least address those things, function to really reassert that kind of racist benevolence in a way, right? These efforts really minimize the racism that we experience, right? And have a very unintended consequence of heightening that hostility sometimes. Because we say, oh, I took the training, there's no way I can be racist, or there's no way I have biases now. and this training is enough. And no, there is a power, there is an inequality happening in the background, right? There are bigger issues: economic oppression, environmental racism, lack of access to healthcare. These are root causes of these biases that we also experience, of that implicit bias in healthcare. And those are things, like, at least as an ethicist or as an attorney, we have to become advocates, right? And fight that bigger fight, in a sense, have that bigger voice to help with those underpinnings, that yes, training will help us in the micro, but we need to talk about the macro, right? And how do we work with those bigger forces that are essentially helping implicit biases stay there, or just inequality in general stay there, and be the standard of care that we are experiencing today that we want to tackle, right? And to be also very, when we talk about all these trainings again, and the cultural competency and the bias awareness, we want to be careful to not create a new kind of stereotype, right? That creates a single issue kind of problem, and it's just implicit biases. No, it's not that it's untrue, it's just that it's not complete. And again, that's why we also need to be aware of the bigger conversation, and how can we become advocates of that bigger conversation. And I would say that's where we start as ethicists and attorneys.
Indeed. And let's talk about that role of lawyers in solving this problem, because as I said, lawyers are powerful actors in our society, and especially powerful actors in the healthcare delivery system. And so that authority can be used as a force for good, just as it can and often is used as a force to obstruct improvement in quality of care in the name of protecting institutional resources and risk management. And I will submit to you that just as redressing implicit bias and microaggressions needs to be part of the standard of care in clinical practice, both bedside and ethics consultation clinical practice, lawyers ought to recognize an ethical obligation to engage on these issues as well. Next slide, please. And in support of this assertion, I would point to several provisions in the rules of professional conduct, the professional ethical code that governs attorneys. And in particular, here we have Rule 1.2, which has to do with the scope of representation and the allocation of authority between client and lawyer. And that doesn't seem at first blush to have any relevance or application to the discussion we're having. So let me illuminate the point. So I eliminated all of the boilerplate about being a zealous advocate. And paragraph F says something that I think really is relevant to this discussion. Paragraph F of Rule 1.2 says that a lawyer may refuse to aid or participate in conduct that the lawyer believes to be unlawful, even though there is some support for an argument that the conduct is legal. Now, what does that mean for us? It means that if you're a lawyer representing a client and you think that the way the institution is addressing or failing to address implicit bias and microaggression is a violation of the standard of care, and that therefore the hospital or the institution is engaging in malpractice, then you have the right under Rule 1.2 to advance that argument, even if you could make an argument that the conduct is legal, because there's no obligation, no explicit, no published, no stated obligation to use the standard of care legal parameters as a means of combating implicit bias. And if you can do that, then you should do that. So paragraph G says, a lawyer does not violate these rules by being punctual and fulfilling all professional commitments, by avoiding offensive tactics, and by treating with courtesy and consideration all persons involved in the legal process. What does that mean in plain English? Well, I'll tell you. That's the restatement of the long-held and often quoted rule that lawyers have an obligation to engage in zealous advocacy. And the term zealous advocacy has come to be misunderstood as the duty to fight every fight that you can, whether it's a good fight or the right fight or not. And so paragraph G was added to the rules of professional conduct for lawyers specifically to refute the notion that lawyers have an obligation to press every legal advantage, even if it fails to serve the larger objectives of a client being a person involved in the legal process. And I take that as a license for lawyers to say to clients, you know what? We should consider redressing implicit bias and redressing microaggressions and calling this out and doing more than just the online training, actually engaging somebody like Nakia, who I plan to keep very busy for the next 10 or 100 years, to do trainings that actually change behaviors, the kind of trainings that involve role plays and involve discussions about the video that you saw and the dozen or so additional vignettes that she included in her full training video. And that if lawyers and ethicists and clinicians who are leaders in their institution assume this as an obligation, as a professional ethical obligation, so standard of care for clinicians, standard of care for clinical ethicists, and standard of care for healthcare lawyers, that we can fix this because we know we fixed, at least in some measure, the problem of limited English patient advocacy. Next slide, please. And this is a bigger problem than just how lawyers react to challenges to their institution's behavior. This is really a question of the competence of the lawyer in being an advocate, a zealous advocate, a champion, as Nakia described she was for her patient at the hospital where she moonlights. This is a measure of the competence of the lawyer required by Rule 1.1 to look beyond the short-term benefit to be gained in a aggressive technical approach to responding to an allegation that clinicians at a particular institution are violating the standard of care, and looking at the larger obligation of the client to provide proper care. So Rule 1.1 can be a tool that we as lawyers can use to promote this discussion. 1.1a says a lawyer should provide competent representation to a client. Competent representation requires the legal knowledge, skill, thoroughness, and preparation reasonably necessary for the representation. B, a lawyer should not handle a legal matter that the lawyer knows or should know that the lawyer is not competent to handle without associating with a lawyer who is competent to handle it. And then C, a lawyer shall not intentionally, 1, fail to seek the objectives of the client through reasonably available means permitted by these rules, or prejudice or damage the client during the course of the representation, except as permitted by these rules. So let's take a closer look at 1. Fail to seek the objectives of the client through reasonably available means permitted by law and by these rules. For the non-lawyers in the audience, what that means is that you should pursue your client's objectives if they are just objectives, and that you should do so to the extent that you are in fact advancing your client's longer-term interests, not just the objectives that they come to you articulating are your obligation in the first place. And this is because, next slide, please. The rules also provide that practitioners should not be engaging in misrepresentations to the court, even if it is advancing a legal argument that they are able in what you could call good faith to make as an argument. So 4.1, truthfulness in statements to others in the course of representing a client, a lawyer shall not knowingly make a false statement of fact or law to a third party. Common misrepresentations. A lawyer is required to be truthful when dealing with others on a client's behalf, but generally has no affirmative duty to inform an opposing party of relevant facts. Well, that's true, but it is also true that a lawyer can counsel a client to disclose relevant facts, such as the inadequacy of a client's efforts in addressing implicit bias and microaggression in the context, for example, of an enforcement action, the likes of which I faced with the LEP services investigation, in order to get to the larger objective and goal of the client, which is to say that when the Attorney General and the Office of Civil Rights came to Wyckoff with their allegations, yes, the duty of zealous advocacy, which existed at the time, would have justified us just wearing the government down and obstructing and disagreeing and taking half measures. But it is equally, according to Rule 1.1, 1.2, and 4.1, it is equally valid and appropriate as a matter of a lawyer's professional obligation to counsel a client that the smarter, better thing to do, consistent with the institution's larger mission and purpose, is to acknowledge deficiencies in care so that you can correct them. And that is just to say, in closing, that the law is necessary, but plainly not sufficient to achieve our ethical goals in medicine. And tonight was just a very small baby step in the effort to acknowledge the issues that we have highlighted, that Nakia has committed herself to respond to inside the institution, that the rest of us who are at some distance from the bedside need to join in as an effort to correct these deficiencies. And that's my presentation. That is my plea. That is my request and my demand of all of you to step up and take part. Because as we all know, if you're not part of the solution, you're part of the problem. I want to thank Nakia Alexander and Jorge Rivera for joining me in this quest. And I see no more questions. I think we'll end for tonight because I have to go teach my 8 o'clock class. But I look forward to seeing all of you at future sessions where we will address the notion of implicit bias and microaggression as an institutional question. That program will be coming soon. Thank you all and good night.
Thank you, guys.
Thank you.